we look at hip fractures and, also, not just hip fractures, but also hip replacements, they're really similar. So there's just one slide about it. Really, if you know this graphic, you should be good. But when we look at hip replacements, this is actually what a hip replacement looks like. Some people are confused at how are you gonna actually replace that joint, right? So what they do is they take the femur and they cut off the head of the femur, and then they take this rod, and it's a femoral stem, and then they hammer that down inside the femur. It's very graphic. And then literally just have a mallet that they hammer it down into the femur. And then what they do is in the femur head, the new one, they have this little plastic piece that's in here that creates a little bit of movement where it can slide, so they still have the same ability to go around and all of that. And then they shave down inside the hip socket so it can sit where it actually needs to be, and they can take away that diseased bone. And that's the new hip. But it's very graphic if you ever get a chance to see one in person. Like do it in the OR. It's, once you see ortho surgery, you understand why there's a painful after. There's a lot of power tools involved. There's a lot of noises, a lot of things happening, okay? But big things for your hips, whether it be a fracture or a replacement, is gonna be positioning. They're typically gonna have an abductor pillow to make sure they're keeping a certain degree between their hips, so they're not closing in, causing any sort of dislocation. You're gonna make sure that you're positioning them really well. If you put them on their side, you're gonna have pillows to position them correctly. We have fracture bedpans and things like that to make sure, because you know, a normal bedpan has like a pretty high angle on it, right? So if I put that under a patient that has had a hip injury or a surgery, then it's gonna tilt their pelvis. Okay, if I tilt their pelvis, then it's putting pressure on the back of the hip socket. We don't want that to happen. We want it to stay neutral. And so we have fracture bedpans that are much thinner, and they don't have that large degree of angle, and so then it keeps their hips in a more neutral position. Typically, they want to avoid like a 90-degree flexion, so meaning like they wouldn't want to squat or anything like that and get their hip and like like their femur to a 90-degree angle for about 4 to 6 weeks is usually about what they're looking at. And then you don't want your hips to go below your knees for 4 to 6 weeks. So that's even like if they were to lay down, you wouldn't want them to pull at the knee of their chest, okay? Any questions about the hips? Okay, all right, we're gonna move on to osteoarthritis. So this is just a progressive deterioration of the cartilage in our articulate joints. So what happens is, this is what it should look like, right? We have cartilage that kind of acts as like a little bit of a cushion. They're able to move, it allows the joint to slide and do what it needs to. When that starts to deteriorate, then we can also actually develop some of these little bone spurs. It's hard to see in this picture, but I think I have another picture that shows it better. That will start to also put more pressure on that cartilage, and it goes away, and then eventually there'll be bone on bone. If you've ever heard, like if you've got an elderly patient out of the bed that has osteoarthritis and you kind of hear that like creaking, like you can hear the grinding on their bones, this is typically what you're listening to. You're listening to that lack of cartilage and just straight bone tissue on bone tissue, okay? Sounds pretty painful, right? Because it is. So, when we look at signs and symptoms, or let's back up, risk factors for osteoarthritis. What do we know are some things that could lead to them being at a higher risk of developing osteoarthritis? Women, yep, women that are at high risk for a lot of these things, and why might that be?
Because of their menstruals.
Yes, because of hormones, right? And they oftentimes will be lacking some of the hormones that are necessary for bone formation and bone strength. They'll have a lot of calcium and vitamin D deficiencies due to their hormone shift. And we know that calcium and vitamin D both have to do with bone formation and bone strength and bone density. And if we are low in calcium, can I just take calcium and it fix itself? What do I also have to take? Vitamin D. You're not gonna absorb the calcium unless you're also taking the vitamin D, okay? Previous injuries, so maybe I've hurt my knee in the past and I've caused some stress there to that cartilage, and then I've kind of snowball effect into some osteoarthritis. Obesity, obviously, for the joint stretch, just the wear and tear on those joints and putting more pressure to cause more of that grinding sensation that can do away with some of that cartilage. And then repetitive stress. So think again for a lot of like the manual labor jobs, or think of athletes that are doing a lot of the same repetitive motions, especially at like high speeds or high weight, things of that nature, okay? Look at, like a lot of football players develop, especially linemen, they develop a lot of issues with their knees, right? Because they're putting a lot of stress on their knees. Catchers in baseball, they have, I would probably venture to say that by the age of 50 to 60, most of your like major league catchers, not like, I mean, you know, if you had your glory days in high school, that's fine, but like if you did this for a living, right? You're catching 6 nights of the week, then you probably are dealing with some osteoarthritis. When we look at the pain, one of the things about pain here is that it actually gets worse the more that they move, okay? When we talk about osteoporosis later, we'll see the opposite, but this worsens with activity. So the more they do, the more they're gonna hurt. That's where we talk about the fact that we have to find that balance. We don't want you to just stop moving altogether, right? You use it or lose it, like we said earlier, but we do need to have some sort of rest period, so finding that balance is important. This does get progressively worse over time. We can do things to kind of slow down the progression of it. Sometimes that's just lifestyle modifications, that sort of thing. But there's not a whole lot that we can necessarily do other than medications and that sort of thing. You'll have people, you know, they're like, oh, I can tell it's gonna rain, that sort of thing, my arthritis is acting up. That actually is true. It's because of the barometric pressure change. So it's not like you're all on Mean Girls, it's like, there's a 30% chance that it's already raining or whatever she says. But so they do actually start to feel a lot of that pressure and pain in their joints when that barometric pressure changes due to the rain. They will have a lot of stiffness, specifically in the morning after they've been still for a long time. Crepitation, don't get that confused with crepitus. But crepitation is that joint cracking and the grinding that you hear. That's that bone on bone. And then Heberden's and Bouchard's nodes. So this is showing you Heberden's and Bouchard's. They can happen on any of your fingers, okay? But they're just pointing it out on specific ones because they're not gonna point to every single joint, right? But your Bouchard's nodes are gonna be your more proximal knuckle, and then your Heberden's nodes are gonna be your more distal knuckle, okay? So like, I'm not gonna get a Bouchard's node on this knuckle, I would get one here. Does that make sense? But I could also get it on any of these 4 fingers. It doesn't just have to be my middle finger or my index finger, like in this picture. And then over time, they will develop some joint deformity, okay? This is a little bit different than what some people associate with rheumatoid arthritis deformity, okay? That's more so when you're looking at like, oftentimes their fingers will actually start to go at like almost 90-degree angles. That's more of your rheumatoid arthritis. So your deformity here is more so because of the node deformity, and then it'll make it look like there's a curvature of the finger, but it's more so because they've got a large bony node over here on this side of it that's kind of tilting it a little bit, okay? Then when we're diagnosing this, there's a few things that we're gonna do. We can do an x-ray, and you'll see here, this side right here is what we would want it to look like. So we want this width where the bones are protected. We have some cartilage in here. And then this is where we've developed these little bone spurs, or osteophytes is what the official name is. On the edge, this is a knee, obviously. And then you'll see here that the bone is just sitting right on top of the bone, essentially. They still got a tiny bit of cartilage right here, but right here, they're just bone on bone. Not comfortable, okay? Then we can get into like a CT MRI. This gives us a little better look at the soft tissue. This is just showing some of the thickening here. And then you have the thinning of the joint space in between your femur. And then you know, like this is your kneecap, and you see a little bit narrowing there as well. What we can also do is we can draw fluid out of the joint. So your knees specifically, they have synovial fluid in them. So they'll stick like it's usually like an 18 gauge needle, pretty big one. Sometimes 16, and they'll stick that into the joint space, and then they draw fluid off of it. And then they can send that for analysis. So one of the things that this does too is it can also rule out other things, okay? So With this, it should be clear, or maybe a little yellow in osteoarthritis, because this is not an inflammatory issue. If it's an inflammatory arthritis, which is like your rheumatoid, things of that nature, then sometimes there's some blood involved. Also, we can rule out things like gout when we do the synovial fluid analysis, because we can see if there's high levels of uric acid in there. So sometimes it's also ruling out other things that can tell us what they're actually dealing with. Those draws are not super fun for the patient. We obviously don't do them, practitioners do. But they're not fun, but sometimes also it can help us a lot to be able to diagnose, and then we can do things like injections and things of that nature that provide them a lot of relief, so. Alright, then what are we gonna do? We already talked about the activity balance. We're gonna want some sort of nice balance between the mobility and immobility, right? Doing things that don't cause a lot of undue stress on our body. So maybe swimming could be appropriate, right? It's low weight bearing, no contact, things of that nature. Could be good options for these patients. Walking could be good, but you have to be mindful, are you walking up, like are you changing incline a lot, things of that nature. Cycling could be good, but I would think more of like a stationary bike, not out running up and down hills, anything crazy, right? No need to be Lance Armstrong. Weight control is obviously another one. This is true for basically every disease process that we talk about, right? If we can reduce our body weight, we can take stress off of our organs, bones, joints, ligaments, all the different things. And so that can help control some of this discomfort that they feel and the stress that's being exerted on those joints. We can medicate them. We can do like NSAIDs, Tylenol, duloxetine is Cymbalta. You see that a lot associated with like some psych stuff, but also it can help with pain control and nerve, like neuropathic pain that's associated with OA and the joint pain that they're having. So it's kind of one of those things that you see multiple different uses for. And then you'll also see topicals. If you've ever seen like Voltaren gel, anything like that, it's a little bit more targeted to a specific place. They absorb it right there. It doesn't last over a long period of time, but some patients get a lot of relief from it. And most of the time it's like an NSAID that they can put on topically. Obviously we would have to be mindful there, if they're taking a lot of NSAIDs and then they're also doing a topical NSAID, we would want to be careful. And then eventually they could need surgery and like joint replacement and that sort of thing if they're at end stage and we're not able to provide them relief with things like injections. We could do a couple of different types of injections. We have lubrication injections, which are extremely painful because they're very, very thick going into a very small space. But they also help a lot. And then we have steroid injections, which yes, technically steroids do what? They decrease inflammation, and this is not an inflammatory process, right? No, but if something's hurting, what is our body then gonna do? Become inflamed, right? It's trying to help cushion, it's trying to help things feel a little bit better. So a secondary problem that they could deal with here is some inflammation in that joint because of the pain and the degradation of the tissue, okay? So the steroid injection sometimes can help decrease some of that inflammation, take a little bit of the pressure off. And they'll do it similar to that picture where they do the synovial fluid analysis. They just stick a big old needle in there and inject it. So those typically, depending on the patient, sometimes they can last about 6 months. Like by about month 4 or 5, they're probably starting to wear off, but they can't do them super frequently. But they'll give them some relief for some months, and then they'll ultimately typically have to do a joint replacement. Most physicians are gonna tell you that they want you to try and hold off on the injections and hold off on the replacement as long as you can. Just because replacements aren't forever. If you get a knee replacement, typically about 30 years is the mark of when you probably need to get another one. So if you get one really young, then you're looking at having, like you're guaranteeing yourself essentially to have another one later. All that being said, if the pain and the discomfort and the issues that you're feeling in your right knee is causing issues in your ankle and your hip and then your back and all this stuff, then they would probably lead more towards, okay, let's just go ahead and do it. Because again, risk versus benefit. Any questions there before we switch to some pediatric stuff? No? Alright. Again, this part should be a review. Just kind of walking you through how kids grow. Things like that are really easy things that they can put on like HESIs and NCLEXs, because you're supposed to know like Erickson's stage of development and, who's the other guy? There's like a million of them. Yeah, Maslow's hierarchy of needs and that sort of thing, okay? So just don't let those things be things that you never look at again, right? Especially when we get into some of these pediatric things, because a lot of times their mobility and their development is stalled or delayed. And so like a super easy question that they could possibly do about like a clubfoot kid, if they have the braces and they're not able to learn to walk at the same time that a lot of their peers are learning to walk, well then what would be a developmental appropriate toy to give them, right? You'd have to know about the clubfoot and what they would be doing, like what restrictions they would have, but then also have to know about your hierarchy of needs and kind of their stages of development. Those are easy things that HESI and NCLEX love to do, especially NCLEX. Alright, so clubfoot. I'm not gonna try and say the fancy word because I mess it up every single time, and I just don't feel like embarrassing myself too much today, okay? And you don't have to know every single one of these. This is just to highlight the fact that there's different names for depending on how the feet are actually deformed, okay? I would never test you on exactly what those mean. That'd be ridiculous. But what we do know is that feet can turn all sorts of different ways, okay? There's different characteristics of it. Oftentimes they look like they're twisted, maybe inward, outward, upward, or down. And we need to obviously fix that. This is gonna affect the position and alignment of their hips, knees, back, all the different things. So ideally, we would fix it when? Early. And what do we know that babies do a lot of? Growing and developing, and they do it at a really fast rate, right? So the earlier we can intervene, the better, and the less, hopefully, interruption in their daily life that we can do, right? It's a lot easier to put a brace on a newborn as opposed to a baby that's already trying to walk, okay? So, some of the things that we'll do is, again, early intervention has the best outcomes. So we can put them in different types of braces, which, yeah. So this is a Dennis Brown brace that this baby has on. We'll talk about it in just a second. But we can actually start to correct those, and it's not gonna be all at once, right? That would probably be painful. Typically, this is not, I mean, you know, babies can't really like voice it to us, but we can tell that it's not painful other ways, right? They're not crying, they're not inconsolable, all of that. They seem comfortable, they're happy, go lucky, whatever it may be. That being said, if they do start to become inconsolable, then maybe I need to start investigating. Is the brace too tight? Is it rubbing them in the wrong place, or whatever that may be? When we are dealing with correction, whether it be bracing or if they did for some reason have to progress into surgical correction, then range of motion is gonna be a big one, because obviously, you know, if I'm moving around, even if a newborn baby is kind of moving around and squirming, they're doing like flexion and all of that of their ankles and feet, right? Well, if I'm putting them in this hard brace, there's not a lot of that. So there still has to be some increase of range of motion. But if I tell a baby that's a week old, hey, I need you to move this left leg, are they gonna be able to do it? No. So who do we talk to? The parents. We make sure that they're educated on how to correctly do it, okay? So this is the Dennis Brown splint. This is where they take two hard-soled shoes. They're typically very specific shoes that they have for this, and then they attach brackets down at the bottom, and they have a bar that goes from shoe to shoe. What this will do is they'll start to slowly tilt them back to get them straight, but then it also keeps them flat and on this hard surface. We can also do corrective shoes, where they can do it in specific shoes, but then also they have braces that they can put in any shoes that you may have for the child. Now we've become a lot more adaptive, and it essentially creates the same hard sole with the stability up the back of the ankle, without the bar in between the feet, okay? Skin integrity is huge here, making sure that we're not getting rubbed on any surfaces. Babies can't tell us, remember, they're just gonna cry if they're uncomfortable. And their skin is so fragile, so it wouldn't take much to really create a problem here. So talking to the parents about making sure they're doing frequent checks of that skin integrity is really big. And also, like, don't get their feet wet and then don't dry them. You know, like, if their feet get wet, dry them underneath that brace, make sure there's not any moisture in there that it's gonna cause any blistering or anything like that. Your assessment is gonna be very similar to a lot of the same assessment that we've already talked about multiple times today. You're gonna do all of your neurovascular checks, we wanna make sure we've got those pulses, cap refill, temp, sensation, all of those, they can move it, they can wiggle their toes, okay? Positioning, if they are, like let's say they had surgical correction of this, then we would obviously wanna elevate their feet, or even if they're in a brace, we might wanna elevate it to create, you know, just to help not have some of that swelling that may occur because they have the brace on. If they have a cast because they had to have a surgery, then making sure that diapering is done correctly, which I'll talk about again in just a second with hip dysplasia. Range of motion, we've already talked about, making sure that they understand that it's important that they wear them as prescribed. Again, these are things that can be removed, right? Well, you could imagine, you've just had this sweet little baby, and all you wanna do is just snuggle them, right? Well, this could make that not quite as enjoyable, right? Or not as easy. And so sometimes parents are like, oh, I'm just gonna take it off for a little bit. You know, like I just want them to nap, or you know, they're uncomfortable because they can't roll or whatever it may be. So making sure that we educate them about the importance of making sure they wear as prescribed, and then the clothing options that could make it a little bit more comfortable, like socks and things of that nature. You know, we love to put socks on babies around here. Skin integrity we already talked about. Any questions there? I've never claimed to be a pediatric nurse. So, if that's a very specific question, I might not be able to answer it, but I can figure it out for you. I have children, but I'm far from a pediatric nurse. Too small of fields for me. Alright, so then we get to hip dysplasia. Hip dysplasia is another one that people have at least heard of, right? And what have y'all heard about it? Anything?
It can be congenital.
Do what?
It can be congenital.
It could, absolutely. So essentially what happens is the joint doesn't develop correctly. Oftentimes the socket gets to where it's not deep enough, it's too shallow. So if you look here, this hip socket doesn't have the ability to hold the ball of the head of the femur in it. So it's constantly dislocating, okay? Obviously, we don't want that to happen, okay? So some of the things that could put babies at higher risk for this is if they were in breech position, and I, even more so not claiming to be a pediatric nurse, I have never even considered for a second being a labor and delivery nurse, so, never. But in breech position, they are feet first. So if you think about gravity, right? When they're in the belly, they're gonna be feet first, they're gonna be kinda like frog positioned, right? What is that putting a lot of pressure on? Their hips. And not only is it putting a lot of pressure on their hips, it's putting a lot of pressure on their hips that's gonna cause their hip joints to go out. So then as these hip sockets are forming, what's happening is they're forming around the hip, like they're forming around the head of the femur, but while the head of the femur should be like this, it's sitting here. And so it never gains the ability to actually kind of close in around the head of the femur. So that's our breech position. Also why, like, multiple births, meaning like there's multiple babies in there, right? They run out of room, right? Or if they're at a really large size in utero, they're running out of room. They're a little bit more cramped. They're putting more pressure on their hips. Maternal hormones. Anytime someone is pregnant, they have an influx of hormones, especially like relaxin, that stretches everything. That's why hips get wider, feet get bigger when you're pregnant, all the different things. And so if that is extremely high, then, or potentially they also have an influx of different hormones, then it could cause some changes in the way that their bones are developing as well. Because when everything with mom goes to baby. Females, it is more common. I'm not real sure for firstborn status. It popped up in everything that I was researching a couple years ago when I was creating this, or doing this lecture for the first time. And I've looked every single semester trying to find some science behind that, and it's not clear. So I don't really know why firstborn, but
Because your uterus is smaller?
maybe.
Maybe.
But you know, it's supposed to go back to its normal size anyways. even if you're on your 10th baby. The uterus itself is supposed to go back to its normal size. And if it's not, then you've got a problem,
Nothing's.
from what I know. Again,
Nothing's normal.
I literally can't stress to you enough how far from a labor and delivery nurse I
Large
would
infants.
ever like to be. Yes, large babies. Now, if they are breech position, most doctors will send them for ultrasounds after delivery, because they wanna make sure, even if they've passed their newborn screenings or anything like that, they'll wanna check those hips after they've been born. And I think that they do that like initially, and then I think they do another recheck, like when they're a month or two old, cause they've grown so much in that first like 6 weeks, they're like a totally different baby already. Early diagnosis, again, just like with the clubfoot, the sooner we can treat it, the better. And then hopefully if we can go ahead and diagnose it and start treating in that first, like 2 months of life, then we have the better success rate and a shorter amount of time that we're actually having to do anything. So, that's it, I don't know why I keep doing that. But when a baby is born, the very next morning, pediatrician comes and does an assessment on the baby. You've ever seen them do that, which y'all will this summer, when you get to the labor and delivery stuff. But they're gonna do some assessment on their hips, and they're doing that to check for hip dysplasia. So they're doing an Ortolani and Barlow maneuver, and they're listening for a click. And essentially what they're hearing is that femur kind of sliding out of the socket. That's the click that they're hearing. They don't want the click, okay? Some other things that you may see is they may have an additional gluteal fold. So if you were to lay the baby prone and you were to look, maybe they have like one little fold under their right butt cheek and they got 2 under their left butt cheek. That means that something's off kilter, okay? Or maybe they have, 3 on one and 2 on the other, and it's not just because they're a chunky baby, right? Like you can tell. There's a difference in chunk and misalignment, okay? And then also there's knees sometimes can be uneven, that's that Alice sign. What else? Shortening of one limb, which is why they straighten them out, so they can see if one leg is longer than the other. Then as they get a little bit older, they're gonna start to have some limited movement because their bones start to firm up a little bit more. They're not quite as malleable as they were. They still are a little bit. They could have that wide perineum. And then again with the abduction specifically is what they might have some restriction with. And then as they get older, even if we've done some to treat it, maybe it hasn't corrected itself perfectly, then they may still have some of that developmental delays, like with walking and that sort of thing, some different balance issues. They may waddle. They could have one leg that is shorter than the other and it just stays that way. You may also see them do the toe walking. That's why if a child ever toe walks, it should be looked into, like what's causing them to do that. It could be because of a tendon issue, or it could be because of hips, or it could just be because they don't want to put the heels down, but better to figure out why. So we can do a few things. Obviously, if we start really early, we can do things like the Pavlik harness, which I've got a picture of on the next slide. Then we can also move into maybe doing some skin traction if we need to. As they get a little bit older, we can do a spica cast, which I also have a picture of, and we'll talk about in just a second. And then if they're much older, like over 18 months, then typically they're gonna have to look more at like surgical correction, putting them in some actual like significant traction, and looking at like extensive physical therapy and that sort of thing to be able to correct it. So obviously, we would much more want to be on this side of that scale, fixing it early so we can avoid all of those. This is a Pavlik harness on the left side here. So this is a removable one. And what they do is they have like little booties that go on their feet, and then they connect to these straps that then connect to a chest strap, and then they have shoulder ones. And they're adjustable. So what they are doing is essentially by putting the hips in this position, it's forcing the hip to go down further into that socket so it can hopefully close around it. That's what that position is doing. Because if they're just sitting like this, they're gonna sit here. But then if they bring their knee up, and then it's gonna slide their femur head back down into the socket a little bit. These obviously can be taken on and off. They're gonna want them in it typically about 23 hours a day. They can usually have it off for a bath, that sort of thing, but then it has to go right back on. They can move a little bit, but they don't want them, they're not like, they don't have the ability to straighten their legs. Obviously, they can pull them up a little bit further while they're in the harness, but they can't straighten. These typically, they can do underclothes or overclothes. A lot of times they'll do like a onesie and they'll put this on and then they'll put something on over it if something will fit. But often you can see that there might not be anything that fits depending on how tight they have those straps. And then this is a spica cast. It's a little bit more permanent of a solution. So this one can't come on and off, but you can obviously see that there's some other extenuating circumstances because what do babies do that I said at a really high rate?
They
Grow. And so if we have a cast on them, you're looking at probably like weekly cast changes, okay? Also, you might wanna change that diaper.
Not really.
I have mercy on any parents that have to navigate that because that would be so tricky, right? Typically they tell them to put a diaper on like the inside to catch everything because you don't need the cast getting soiled or wet or anything like that, and then you put another diaper on the outside for another layer of protection. But that would be really tricky. And I wish that this picture, I redid my presentation this semester. I wish that this picture could have fit where you could have seen that baby's face because it is literally the cutest baby I've ever seen in my entire life. You could Google a picture of a baby with spica cast, and if you find this one, you'll see what I'm talking about. It's like the little rosy cheek, like fat, plump face. It's adorable. And I was really sad that I couldn't get it to fit on this new PowerPoint for you to see the whole baby. But, all right. So we've already talked about most of this. Make sure that they're putting it on how they should. Skincare, diapering, development. That's what I kind of talked about with like, make sure that they're stimulated. So if they're in this big old cast, they're not gonna be sitting in the same little seat that you can put them on, like put a average developing child and it doesn't have the hip dysplasia, right? They're not gonna be sitting in a high chair the same way when they're 4 months old or 6 months, whatever. So making sure that they're having adequate stimulation, they're still doing like working on fine motor skills, they have the appropriate toys to play with and that sort of thing. Any questions about hips? We are rolling. I might make it home for bedtime after all.
Me too. Keep on like this, we do.
One thing about me is I can move quick if I got to.
Like,
Again with the empty cup, oh my god. Okay, so osteogenesis imperfecta. So osteogenesis imperfecta or brittle bone disease. I'll call it OI just because it's a mouthful. Have you heard of it?
yes.
What do you know about it?
The bird bones is
Oh, you're good at repeating also.
fragile bones.
Fragile bones, yeah.
You
What else
fall
did you say?
break.
Infection, what about infection?
Infection, bones that have to be on some kind of steroids.
Is it
I
an
mean,
infection?
Well, if it gets into the bloodstream, it's probably that bone marrow is still getting like where it's not supposed to go from the breakdown.
Okay. We're not gonna go that deep into it. We're mainly gonna focus on the fact that they have a low bone density, right?
Isn't it, an autosomal dominant trait, it affects the dominant?
Well, it's a genetic trait,
Well, it's genetic.
yeah. And so
Does
to
it
have
affect
active
the
disease,
dominant?
I believe so, yeah.
Yeah.
So you would have to have 2 parents that carry the gene. But, yes, so,
Shriner's commercial,
do what?
the Shriner's commercial.
Yes,
That
yeah.
kid.
And there's a wide range of what these patients can look like, okay? So you can have patients that have very mild OI, that it's just easier for them to break a bone. Like if they got tackled, it would break a bone. Whereas if I got tackled, it would just bruise my ego a little bit, right? Or you could have ones that if you hold their hand, it breaks their hand. Not, you don't even have to squeeze it, just the holding of their hand. Or if they brush up against something, it breaks their arm. So they can range greatly in severity, okay? That's why sometimes if they don't do the genetic testing and things like that, they don't know if it's a less severe case, like really mild, okay? Alright, so we do have, a genetic component here, which is why if, pregnant women or pregnant families decide to opt for like an IPT, testing while they are pregnant, it will screen for this. Now, that does not tell them that they absolutely have it, it just says that they, are at a higher risk of having it, that they screen positive, they would have to do further testing. But also, that sometimes it can be diagnosed in utero because they see multiple fractures, on ultrasound. So these babies will oftentimes, if they're a severe case, they'll have fractures in utero, which also makes delivery very traumatic for them. It's not, I mean, delivery is traumatic anyways, but, delivery on a baby that, is this fragile, can be really scary. So there's a lot of components there to think about. And there's some severities that are deemed like not compatible with life, okay? Making sure that they understand once the baby is born, that there's gonna be a lot of differences in the way that you're able to handle them. That you may not be able to swaddle them tightly like you would an average baby, or you can't hold their ankles together to change the diapers. Life is gonna look a lot different, okay? If you do have a patient that has OI and they come in to be treated for fractures, what might it also be confused with? Abuse. Because there may also be some fractures that show up on x-rays that the family didn't even know about, right? This can sometimes start to affect life expectancy, especially in those severe cases. If you think about it, if you were to break, ribs, or really anything, honestly, but if you were to break ribs, when it heals, what's gonna happen is they're gonna develop a lot of scar tissue, okay? So that's gonna become a little enlarged. Then let's say they break it again, and then again, and then again, and they keep building up more of the scar tissue. What's gonna get smaller?
Your chest cavity.
Your chest cavity, and what's in there? Your lungs, your heart, okay? If we lose the ability to be able to inflate our lungs to their full extent, then we deal with some respiratory issues, some potential heart failure because it hasn't had the ability to expand and pump in the way that it needs to. Because these patients can also deal with a much lower or shorter life expectancy as well. It is more common in boys than girls, and just like I said, it can vary in severity greatly. So, if we had to guess, these patients are obviously gonna look like they have multiple fractures, okay? And a lot of times when we do assess them, they may have multiple fractures that are at different levels of healing, right? They're not necessarily all happening at the same time. They can have some deformities from the way that they do heal, and also that scar tissue that they form. They can have some spinal column abnormalities because those can be fractured as well, and they're just not developing the way they need to. And then they have a short stature, meaning that they're not growing in the same way that an average person would. Some of the non-skeletal features, blue sclera is like your classic sign that they call me. No, sclera is where?
The white.
Yeah, it's in your eyes, okay. I just gotcha, I had somebody one time that didn't know, so, your blue sclera, so the whites of their eyes have like a bluish tint to them, okay? They could also have, be easily bruised. So again, if you just touch their arm, maybe they'll develop a bruise. They typically have some hypermobility. So a lot of times what people, refer to as double jointed is probably because you got an issue, right? A lot of times, it was everybody said they were, oh, I'm double jointed and all this stuff. And then Ehlers-Danlos became more popular for diagnosis, because people were looking into it a little bit more. You're not supposed to be double jointed and have these super hypermobile joints, okay?
I love joint. Well, we got something wrong with you.
And then muscle weakness, obviously, hearing loss is another one. And then dentinogenesis imperfecta is essentially, a lot of the same components that we have in our bones, we have in our nails and teeth. And so then they lose the ability to, develop their teeth in the normal way, so they'll have, just some abnormalities with their teeth. Sometimes, seeing where the teeth are really small, they are very discolored, there aren't very many spaces in between the teeth, you can't see, it just kinda looks like one big piece of tooth. But they can look very different. That's not every single OI patient, but it is something they can have. what are we gonna do with them? What, if you had to guess, what's the biggest thing?
Safety.
Safety. Safety, 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 safety. I can't say it enough. That's the biggest thing here is safety, but also how can we talk this family through navigating this while allowing them to still be a kid, right? So maybe football's not an option, but maybe swimming could be, right? Or maybe baseball's not an option, but something else is, or whatever it may be. Maybe cheerleading isn't an option, but playing a piano might be. So finding things that would be more appropriate for them that would still allow them to socialize with peers of their same age. Finding them support groups for both the children and the parents, right? Because this is traumatic for both. Sometimes what we can also do is promote like bracing. I mean, you can't brace every single bone in your body 24/7, but if they know, oh, we're gonna go out to Disney World, we're gonna be walking a lot more, right? We're gonna be in crowds. Maybe we're gonna wear leg braces today to just provide a little bit of extra support when we know we're gonna be out walking a little bit more than usual. So supportive devices can be nice. Again, it's not gonna be a fix all the time, but an option. Making sure that they're in a safe environment, not only with you, but also at home and when they go out places as well. Ideally, they could potentially still create a safe environment for these kids in school, if they're at school age. So we want them to be able to experience some of those normal day-to-day activities. And then medically, oftentimes these patients will be prescribed bisphosphonates, which help with bone marrow, or not bone marrow, but bone production, and bone density, and then calcitonin and growth hormone as well. I mentioned genetic counseling because there is that genetic component, and that's obviously totally optional. But a lot of times the reason that they mention genetic counseling is because, let's say this is their first child, and they're diagnosed with OI. They wanna open the door for that family to learn, totally optional, the probability of future children having OI, right? Now, they can't tell you for sure, yes, this kid's gonna have it, and this kid's not gonna have it, but they can tell you, okay, well, yes, you have a 75% chance of all of your kids having it, or whatever it may be. Which we know could greatly affect some of their decisions when they're looking at their family planning. And then also, let's say that it's a really, really mild case, right? Then maybe they'll look at that genetic makeup and that component to see if there's a certain type of that gene that they're carrying that makes it less severe, which could also help them later in their life when they potentially are looking at expanding a family, right? But again, totally optional. Alright, any questions about OI? Alright, we're gonna knock out osteoporosis and get out of here. Sound good?
Sounds yes.
So, our time together was short and sweet, but
We'll get you.
we'll make it up.
In the summer.
Yeah, shoot, I'm gonna be trying to be short and sweet and so too. I'm only working half-time, so.
We like you for that.
Yeah, I'm only working part-time this summer. Alright, so, when we look at osteoporosis, I put it at the end away from osteoarthritis because I don't want you to get confused because it obviously sound very similar. But osteoporosis is when we're actually dealing with a metabolic disease that is causing the bones to demineralize or the density to go away. So remember, we're talking more about degeneration with osteoarthritis, and now we're talking about the inside of the bone is demineralizing. So we lose a lot of calcium and phosphorus out of the bones, which causes that lack of density. And then that puts us at a much higher risk for fractures and a much higher level of fragility. And again, who do we know would be at a high risk for this? Women, especially postmenopausal women, because there is a gigantic hormone shift. And we know menopause can be caused both because of age and the natural progression, but also if someone were to have like a total hysterectomy or whatever, and then they're having to artificially replace hormones, this would also be they would be at a higher risk of developing osteoporosis. Because we've essentially, when you have a total hysterectomy, you're essentially causing menopause, right? We have two types, the primary and secondary. Essentially, the primary is because, unfortunately, we all get old. Well, I mean, ideally, we do, right? We want to get old. I shouldn't have said unfortunately, but well, we gotta do it at some point. We want the opportunity to do it, right? I'd rather get old than not. So.
I mean, there's only one other option.
Right, and I don't wanna do that. And then we have secondary, which is more due to like like if you had hysterectomy or you had other disease processes that were causing some issues with, your calcium, phosphorus, and bone density as well. So, when we look at this, essentially, we kind of regenerate all of our bone density. It's like kind of like a constant cycle. So what's happening is that is getting, like our bone density is getting, less dense faster than it's able to kind of regenerate and rebuild, okay? And then we just talked about the primary and the secondary, so we won't really go back into that. Secondary too can be caused by medications. Corticosteroids is a big one that can put people at risk of having osteoporosis because it breaks down the bone. So long term, we're not talking like, oh, you're in with a COPD exacerbation, you've been on steroids for 2 weeks. We're talking long term, like months to years of daily corticosteroids putting you at a higher risk of this, which is not uncommon, especially in autoimmune disorders. Lupus, rheumatoid, fibromyalgia, all of those, oftentimes those patients are prescribed, even if it's low dose corticosteroids for daily use, which then puts them at a higher risk for this. We've kind of hit most of these. Smoking puts you at a higher risk for everything. I mean,
That's
just
right.
is what it
That's
is.
what's wrong. And
So,
you're-
you know, it's bad for you, don't do it. Sure, it's nothing you haven't ever heard before. But smoking, also excessive alcohol consumption, and I'm not talking like, I mean, I like a cold drink too, but I'm not going out and drinking like 15, 20 of
I
them
mean,
a
I
night,
think at this
right?
point, we needed to get through nursing school, you know, so.
Yeah, you know, at this point, we're not looking at like, oh, you're just like a casual consumer, right? You're like a dedicated consumer, you're like a top fan, okay?
Top.
So, that's more so what we're looking at. When it starts impeding on your daily life is when we're more so looking at putting it at a higher risk for this. Also dietary, if you're not intaking your calcium and vitamin D, then how are you gonna get it, right? If you don't eat anything that has those things in it that we need a nutritionally balanced diet. We're not getting it in our meals, and we're not taking it in the supplement, then how in the world else are you going to, right? And then medical factors, we already kind of talked about that. Family history does increase your risk, but I think we hit everything else. Alright, so kyphosis, which is more of that hunchback, is one of the things that you would see. Height loss, so significant height loss. My sweet little grandmother's about to be 96. She used to be 5'7", she's like 5'1" now. She's a little bitty old thing now. But she has osteoporosis, and one of the things that we noticed first, before she complained of anything else, was the fact that she was getting short. I was like, dang, I know I'm not getting that tall. I mean, I am tall, but I had kind of been done growing at that point, I think. And so she started getting short. Pain patterns, so this is, they're typically going to start describing more of their pain in their trunk. So think like back, hip, pelvis, it kind of stays here. Now that doesn't mean it doesn't also go other places, but that's most of the time where they're describing the majority of their pain and discomfort. That twisting, moving, is gonna make it worse, but typically if they're moving in a way that is healthy for them and safe and they're not overdoing it, that movement does help some, because they're just exercising a little bit. So, what are we gonna do? Again, safety, right? So take it back to all your 112 fall safety stuff like rugs, cords, all of that in the home, because we don't want them to fall and break anything. That we know they would be at a really high risk of breaking something. We don't want that to happen. Exercise is something that we are going to encourage because we want them to potentially do like some weight bearing and resistance. That helps build some more muscle. We talked a lot, or not a lot, we talked for a few minutes about your core strength and that sort of thing when we're looking at a patient that is lacking some of those abdominal core muscles and how it helps hold us up. Well, if we can help build those, then it can help improve balance. If we improve balance, they're less likely to fall and break a hip or a leg, right? Nutritionally, making sure that we're educating them about being sure that they're getting in plenty of calcium, vitamin D. Protein is always good, it helps with bone and muscle. So then, you know, if you don't have enough protein intake, what does our body start doing to its muscles? Eating them, right, essentially, because it needs to get it somewhere. And so it starts taking away the muscle that you already do have, to replace what you're not giving it. Caffeine and alcohol, we wanna limit it. And then we wanna make sure that we're being very careful about how we're handling these patients and repositioning, because we don't want to accidentally cause any sort of injury. And then proper body mechanics, remember lift at the knees, not your back. And if you've got bad knees too, sorry, you're just SOL. So. And then we can also do some things pharmacology wise, so calcium and vitamin D, this takes you back to remembering, which all of y'all knew. If you're gonna be taking calcium, you should be accompanying that with vitamin D as well.
They come together.
Bisphosphonates again, which we also talked about with our OI patients, it helps with that bone formation. It helps slow down the breakdown in the metabolism of the bones. Alendronate and zoledronic acid are the two most common ones. Zoledronic acid is reclass, if you've ever heard of that. Oftentimes, there's some that they can do PO, but they can also do them in an infusion. Those typically are done like either at an infusion center or rheumatologists can do them in their office typically. Reclass is like once a year. And then some of the other ones are like every 2 months, 6 months, it just depends. Let's see what else. We can do some monoclonal antibodies. You don't really need to know that specific medication. I just wanted y'all to know that there were some other things that we can do. Monoclonal antibodies, if you're not familiar with them, essentially what we do is we take antibodies from someone that has already built up an immunity to something, and then we can give them to somebody else, and then hopefully they start to develop that. We saw a lot of that during COVID. We were doing monoclonal antibody infusions. So essentially like somebody that had had COVID and had recovered, we would draw blood from them and then retract the monoclonal antibodies from it and then give it to a person with active disease to help recover. And so they kind of do that in a roundabout way for osteoporosis to slow down that bone metabolism. And then we can do some estrogen receptor modulators, which essentially means we're messing with the hormones. And then teriparatide, it's just essentially, it helps build more bone, and more bone density. But that's not something that you see super frequently, it's also a very expensive medication, so, which most of these are. I mean, every medication is expensive, we charge like $8 for an aspirin at the hospital, so, they're all expensive.
I'll bring my own.
Yeah. Any questions that y'all have for me? No? All right.
I like your
Thank
teaching,
you.
you should come back on the side.